Thank you very much, Tani. Thank you for that very kind introduction. And it is always a pleasure to come to the Malaysian Congress, and we are repeatedly impressed by both the scientific program and, of course, the hospitality is world class. It's absolutely the best. And thank you so much for attending this lecture. I know it's fairly early on a Sunday morning, and a lot of you would have dragged yourself out of bed. But it gives me great pleasure to speak, and the good thing about the Singapore lecture is I'm always given a bit of a free hand to decide what I'd like to speak on. And this year I thought I would speak on operative vaginal deliveries because I think there are some contemporary issues that we need to explore with regards to that. Before we start, a little bit about my hospital. I work at the Singapore General Hospital. It's a general hospital, so it has got many departments and many units. Our hospital was founded in 1821, and that's not to say that the building today is 200 years old, but on the same site there has been a hospital since 1821, and at present we have 1,600 beds, and we see about 1 million patients a year, not ONG only, of course, across the specialties. We have about 10,000 staff, and many clinical departments which can sometimes make the allocation of resources quite challenging. We also now have a medical school which is a graduate entry program, and it's a collaboration between the Singapore side and Duke University in the US. So some pictures there. The one at the lowermost right is the sort of oldest pictures we have of the hospital, and those are in the early 20th century. And at present, the only part of the hospital that was built in the 1920s is Boyer Block, which has got that our iconic sort of clock tower. So you can see in the lowermost left picture, that's the older part of the hospital there, and in the background, the newer part, which is built in the 1980s. Next, I'm going to show you an artist's impression of how my hospital will look like in 10 years' time. So it doesn't look like that today. But if you look on the right-hand side of the picture, some of those buildings are now in place, like our medical school and so on. But this whole sort of campus will be ready in 10 years' time, and I hope there's no delay, because I'd like to work in this hospital, even if it will only be for a few years before I retire. But what I wanted to speak on today was really about operative vaginal delivery, and I'll tell you in a short while why I think that's important, and that's really with regards to modern day trends. And so I'm going to tell you a little bit about the trends worldwide and in our hospital as well. And I'll speak about the obstetric forceps and the vacuum assisted delivery, because those are the two methods that we use today. And while there might be some new methods in the pipeline not yet approved, but perhaps we will see in our lifetime. So I'll speak about the evolution of both these methods and their use today. And then I'll speak about forceps versus vacuum and what we know about the evidence when we compare them both. I'll share with you some data from my own hospital. So these two charts actually show the trend of operative vaginal deliveries, and they pertain to the US, but I think they are generalizable to a lot of different populations. And if you look at the top, that is actually the forceps delivery rate. And as you can see, it was in the early 2000s. It was already low. It was 1.3%. And right now in the US, they're actually quite uncommon. They're less than 1%, about 0.9%, which is surprising if you think about it, because in the US, it was the favored instrument in sort of the early 20th century and all the way up to the 1980s and 1990s. And if you look at the vacuum delivery rate, although it now surpasses that of the forceps, but there has been a drop even in vacuum deliveries. And now in the US, they run at something like 4%. So the combined operative vaginal delivery rate in the US, forceps and vacuum, is going to be less than 5%. Some data from my own hospital, and we're not very happy with our cesarean section rate, and as you can see, it runs in the 30s, 30%. Unfortunately, being part of a general hospital, a lot of our patients have other complex issues, so we sometimes can't get away from the need for cesarean section because they may have complicated heart or renal or other problems. But I want to tell you that it's not for a want of trying, because if you look at our operative delivery rates, if nothing else, they have been actually rising. And while we used to run at about 6 to 9% in the last 4 years or so, we run at about 10%. The other thing that perhaps a little bit unusual or different from our hospital, and I'll go into some detail a bit later, but if you look at the preferred instrument, the last line in this, then it has not always been the vacuum. And although there was a resurgence of the vacuum, it was a preferred instrument from 2008 to 2010. Some years actually the forceps deliveries exceeded the vacuum, and now it's been sort of toggle forceps vacuum, and we do have almost a 50-50 sort of rate in the last few years. So if we look at the evolution of the instrument, and this itself is a fascinating topic, because there are writings from even from 500 BC by Hippocrates, the Romans, and even in Indian and Hindu medicine on the use of the obstetric forceps. But these instruments were then always to deliver a dead baby. You know, the mother would have been in obstructed labor for 2 or 3 days, and it was a desperate measure really to save the mother rather than the baby. And we owe our current instruments really to this gentleman, William Chamberlain. He and his sons, and he had a preference for the name Peter because he had 2 sons and he named them both Peter. And they were known as Peter the Older and Peter the Younger. And they were sort of like the first man midwives, all right? So they were males involved in childbirth. And they developed this instrument which they jealously guarded. They guarded the secret so closely that it is said when they went to deliver a woman, they would usher everyone out of the room. The instrument would be brought in a golden case. I don't know why it had to be made of gold, but anyway it was. And they blindfolded the woman. They blindfolded the woman and they performed the delivery. And they said, you know, they could save babies, they could prevent prolonged labor, and it was probably the first time they used it for the baby as well as for the mother. This was in the mid-16th century. They were French originally, and so they decided they would travel back to France and try and sell this secret to Marichaux, who we will remember is the person who devised the MSV maneuver that we use for the after-coming head for the breech. And of course, when they turned up in Paris, what Marichaux did was he said, okay, I have the perfect woman for you to deliver. And who did he give them? He gave them achondroplastic woman with rickets. All right? And they couldn't. They applied the forceps and they couldn't deliver this baby. And so they left without being able to sell the secret. And we all know, of course, even then, they discovered the first contraindication to actually performing an operative vaginal delivery, which is CPD. So while we can overcome other things, we can't overcome absolute CPD. And what was interesting is the Chamberlains, so they were criticized for this. They kept this secret so well. They shared it with no one. And long after they had died, in 1813, the instruments were discovered under the floorboards in their family home in Essex. So this is an example of how they were discovered under the floorboards. And it was only after that that, you know, people were able to look at the instruments and modify the use. No less fascinating is the discovery of the vacuum, of course, but it is somewhat a much newer instrument because we're talking about really the 18th and 19th century that the first vacuums were discovered or developed. And James Young Simpson from Scotland, Edinburgh, he is given the sort of honor of being the first person to do that. And he used a sort of a leather-based cup and he attached it to a hand-operated pump. And he was the first to have described it to use to deliver a baby. But it was not until the 50s when Malmström from Sweden actually designed a cup which could produce a chinon. It was connected to an electric pump, and that is actually when it started being used in modern obstetrics. And there were some modifications which followed. So these are some examples. And the top one, the one with the tubing, that was Malmström's original cup. And as you can see, the tubing attaches right to the top of the cup. And later on they devised a chain, so they used the chain for traction. Some of you may have used this in clinical practice. Certainly when I was a trainee, some of these were still in use. But people modified the cup slightly, and as you can see, just by changing the position where your suction tubing is attached to the cup, you can actually put the suction tubing on its side, and this was actually a modification by G.C. Bird. And G.C. Bird trained in the UK, but he worked largely in Kenya and Papua New Guinea, and he said if we put this sort of tubing attached to the side of the cup, we can use it to maneuver into difficult positions like in occiput posterior position and so on. And most of you will know Aldo Vaca, and some of us here, myself in particular, I'm honored to have been able to have met him in person, and he has conducted workshops in Singapore and Malaysia. Some of you would have attended. And he modified it further, and he's often given this title, the father of modern vacuum assisted delivery, because the Kiwi cup, which all of you will be familiar with, is actually quite a marvel in innovation, because the tubing actually attaches to the center, but it's on a hinge. So it's often called the Omni cup because you can lay it on its side, you can lay it directly. So it's useful both for occiput anterior and as also for malpositions. The other things that he has innovated with is actually the tubing. If you look at your Kiwi cup, the next time you look at it, you will see two little markings on it, and they coincide with 6 centimeters or 11 centimeters from the cup, which actually correlate to our proximal and distal interphalangeal joints, and actually allow us to do a vaginal examination and kind of estimate how far that flexion point where you apply the cup is from the introitus. I just want to go on, and I'm not going to talk about the nitty-gritty of vaginal delivery because of operative vaginal delivery, because this audience is an educated audience. Everybody would have, or most people would have forceps and vacuum deliveries. But I'm just going to talk about two sort of innovations of the forceps and the vacuum, which were taught to me when I was a trainee, and I think they are not taught well enough or often enough to our junior doctors. So I just want to sort of touch on these, and perhaps you will bear them in mind when in future perhaps you are training someone else. And the first is Paget's maneuver, and when I started doing forceps deliveries, my consultants emphasized this to me, and it was this gentleman Paget who lived in the 19th century and was from Paris, and he realized that of course the birth canal is boot-shaped, right? It is not sort of a straight line. And the line of traction initially, at least when you perform a forceps delivery, is at an angle of 45 degrees to the horizontal, which is a problem because your forceps blades are attached to a straight handle, and so he devised a maneuver to effect this. And of course this is what we have to do when we do a forceps delivery. The initial traction is downwards, and then you need to lift up. The initial traction is difficult because it means you have to pull almost straight into the ground. And he therefore said that if you do this maneuver where, you know, your right hand, it doesn't matter which order, but normally a right-handed person would track horizontally on the handles, and with your other hand you vertically compress it downwards with downward pressure on the left hand, the resultant force of course draws the fetus in a 45 degrees angle right into the floor, and that is the direction of the birth canal. And subsequently people have shown that actually Paget's maneuver not only effects an easier delivery, also reduces the risk of injury to the mother, because then your direction of traction is the correct sort of plane. And this is another example of how that maneuver is performed. And I think that's not taught often enough, because we're often told to pull downwards, but you will never be able to get that appropriate angle without doing the Paget's maneuver. And if you talk about the vacuum extractor, and I think credit should go to Aldo Vaca because he made it a science. And when I started training, the only principle we were told is you apply the cup as far to the occiput as possible. But if you look at it, there's a very precise point that we need to apply it on, and that is the flexion point, which has been devised to be, which has been found to be about 3 centimeters from the posterior fontanelle. Okay, and if you do a little bit of mathematics, you'll know that the distance between the fontanelles is actually 9 centimeters. And if you look at the appropriate placement of the cup, and we are referring specifically to the Kiwi Omni cup because that's optimal for all positions, the diameter of the whole cup is 6 centimeters. If you place it on the flexion point, there is an additional 3 centimeters between the anterior fontanelle and the rim of the cup. So if you're confirming placement of the cup to be appropriate, then one way is to put 2 fingers between the anterior fontanelle, if you can feel it, and the rim of the cup, and you should be able to place 2 fingers there. If you have initially done a vaginal examination and you can feel the posterior fontanelle, then you know a correct placement of the cup will mean that the rim of the cup will just cut your posterior fontanelle. So this is how we can double check position. And of course, position being the essential thing in application of the vacuum. So knowledge of the flexion point is absolutely essential. But Aldo Vaca took that one point further, and this I think is probably something that we owe very much to him, on the fact that because especially in OA and OT positions, the head is well flexed, whichever direction you sort of rotate the head in, whether it is LOT or OA, the flexion point always stays in the midline plane of the pelvis. This takes some understanding, but if you can just imagine a well-flexed head, however much you turn it round and round, that point in the center, the flexion point doesn't change very much, it stays there. And the only sort of position where the flexion point can vary a little bit from the midline is your OP position, the one on the extreme right of your screen. And because OP positions have a degree of deflection, that kind of throws the flexion point a little bit away from the midline. Now what that means to us is that whatever position we are doing a vacuum delivery for, and I'll take OT position as an example in the next picture. And if you draw that red line which actually passes through your urethral meatus to your anus, so that's your midline point, then your vacuum cup is always going to sit on that midline point. The only variation is because in an OT position, for instance, you have a little bit of asynclitism. Your sagittal suture may be a little bit higher in the pelvis or lower in the pelvis, but if you're looking at the pelvis, you're always going to apply it in the midline, but it's either going to be closer to the urethra or closer to the anus. So this is quite a marvelous finding actually, because it takes away the stress when we're applying a vacuum cup. You know that you're always going to be close to the midline, and the only variation is really going upwards or downwards. You might in an OP position need to stray a little bit to the right or the left of the midline, but certainly not into the far reaches or the corners. So I think in applying a vacuum cup, that is of course critical, because application at the flexion point is what affects delivery. So if we get to the hard truths, because it's forceps versus vacuum, and we know forceps are rapidly on the decline in the US in particular, and possibly in other parts of the world, we need to objectively look at the evidence of why this might be the case. But certainly when you do look at it, there is vacuum compared to forceps, less maternal perineal injury. And Abdul Sultan and Rani Taka shared that with us, and the odds ratio is about 0.4%. There are more cephalohematomas and more neonatal retinal hemorrhages with the vacuum when you look for them. But if you think about them, these are actually clinically insignificant injuries, because cephalohematomas look a bit unsightly, don't generally cause any harm to the baby because they are invested by the periosteum. They don't really enlarge. Retinal hemorrhages, insignificant, don't cause visual disturbances and always disappear spontaneously. There's more maternal concerns about the baby, and these are shown in large meta-analyses as well. And one reason we attribute to that is, of course, following a vacuum delivery, you have a chinon, you have a swelling on the head, and the mother sees that she's shocked, she's scared that there might be something wrong. But of course, with a little bit of counseling and reassurance, that's something that we can get over. And it's more likely to fail. We know that if you use a vacuum delivery, you're more likely to fail when that's the instrument of first choice. And that's something to be borne in mind, because surprisingly, even though there's a higher failure rate, there is no difference in the cesarean section rate. And how do we sort of explain that? And the fact is that in the cases that fail vacuum, then most of them either have a spontaneous delivery with the next push, or in a small number of cases, the obstetrician might make a decision to say, okay, I've done a vacuum delivery and there's been a detachment just before the head is delivered, and they choose to proceed to the forceps and safely deliver the baby. So we can tell people whether you choose the vacuum or forceps, you don't have a higher cesarean section rate, you might have a higher failure rate with the vacuum. There's no difference in the need for phototherapy, so that's important. No difference in APGAR scores. And the next statement for me is the most important. There is no difference in long-term neonatal outcomes. whether you use vacuum, forceps, or spontaneous delivery, when that child grows up, they have an equal chance of being a normal child. And really, it would never be anything but this. If it had been something different from this, we wouldn't have been doing vacuum or forceps deliveries. And I think that's something we need to bear in mind whenever people talk about the sort of medical legal concerns about using instruments. The RCOG says instruments are complementary and obstetricians should be competent with both. And this is an important thing to bear in mind, because we are going to lose things if we can only use one instrument. We were interested in what influenced our choice of instrument at SGH. So one of our medical students, and she's still looking at the data, she's trying to collect about 1,000 operative vaginal deliveries and compare them. But I asked her to give me some initial data, and she's collected about 200 patients for now, and I'll share some of that with you. So we looked at 182 consecutive vaginal deliveries, and that particular time period that we're looking at, there were 100 forceps and there were 82 vacuums. So these are consecutive, so remember in my hospital it's about 50-50. And not surprisingly, no difference in the sort of patient age, nor gestational age or parity. And now interestingly, in our cohort, the anal sphincter injuries, and we're still collecting cases, so this may be a reflection of a smaller sample size, but they were not significant really. The third and fourth degree tears were same in both the vacuum and the forceps. And I wonder, because Abdul Sultan was saying sometimes it's a matter of who's at the other end of the instrument and making an appropriate episiotomy and so on. And when we collect 1,000 cases, I'll share that with you again, but perhaps there may not be as much a difference as we think there will be. And if we looked at the complications, neonatal injuries, we didn't have any of the sort of subaponeurotic skull fractures or serious injuries. There were 2 cases of shoulder dystocia, and in one of them the infant sustained a fractured humerus from actually trying to deliver the posterior arm. But both were in the forceps group, but one can say this is not related to the instrument per se. This is a subsequent event following the delivery. NICU admissions, though the absolute numbers appear to be greater in the forceps, they were not actually statistically significant, and most of these babies were admitted for transient tachypnea or temporary sort of respiratory complications. So we were interested what influences the decision. So we looked at all our obstetricians, their year of graduation. Okay, those who did, we said they would have to at least do a significant number of operative vaginal deliveries, and we tabulated them. So if you look at this, and from the most senior on the left hand side to the least senior, those are the consultants. And if you look at their, we devised the ratio of preferred instrument to alternative instrument. That's the 4th line from the top, right? And so it varied from people who had very strong preferences to people who had mild preferences. But if you look, there isn't really a correlation on year of graduation. So our most senior obstetrician had a strong preference for the forceps, but subsequent to that, the second most senior had a strong preference for the vacuum. And if you look at our trainees in the last column, the preferred instrument for our trainees is the forceps at the Singapore General Hospital. And I think what I conclude from this, it is largely a matter of personal preference, okay? And also, young people tend to take on the sort of habits and the training that they receive. So if we are to ensure that the next generation can do vacuum and forceps, then they need to be exposed to that by their seniors. And that's something we need to strive towards. I just want to touch on the never situations for operative vaginal delivery before I conclude by telling you why I think it is absolutely necessary for us to address this issue of declining operative births. We know we should never do an instrumental delivery in modern obstetrics, at least if your station is above spines, because that's a high delivery. And unknown position. Okay, when I was a trainee, there was some people would tell us when you don't know the position, you do a vacuum. And we know that's not true anymore, because you need to apply the vacuum to the flexion point for it to be effective. Cervix not fully dilated, again something people used to say you can do a vacuum if you're 9 centimeters, but there are maternal deaths reported when you do operative vaginal delivery prior to full dilatation. If it's under 34 weeks, it's an absolute contraindication to using the vacuum, and in fact from 34 to 36 weeks there's very little evidence with the vacuum, and many people will be cautious. And this is something we will lose if we can only do the vacuum, right? We will not be able to deliver babies certainly below 34 weeks, and 34 to 36 weeks is a bit controversial using the vacuum then even. And face presentation, we will also not be able to deliver anyone with face presentation if we do the vacuum alone. Now, why do I think we have to be proficient in operative vaginal delivery? And I just want to quote this one paper. It was in 1999, and I remember this paper well because I had just sort of finished my membership exams. And this was a study of 500,000 women in the US. It is an epidemiological study, so they were looking at data. And it had mode of delivery and the risk of having an intracranial injury. Okay, so what they looked at was they looked at people who had an elective cesarean section before labor and people who had a spontaneous vaginal delivery. So you had the lowest risk of intracranial hemorrhage if you had an elective section before labor. Now the absolute differences are close, but if you look at the three categories of women in labor, that means if you had an emergency cesarean section in labor, or if you had a vacuum assisted delivery, or if you have forceps assisted delivery, the intracranial injury rates were not statistically different. Now what this tells us is that if you're already in labor, whether I subject you to a Caesar, subject you to a vacuum assisted delivery, or subject you to a forceps, you have the same chance of having intracranial injury. So we shouldn't be of the view that we have an increased risk of causing this damage to the baby if we do an operative vaginal delivery. But the second point is even more important. This reflects real life practice, right? So that means you do a vaginal delivery if you can, spontaneous if you can, if not you use the forceps or vacuum, and if you cannot you do a cesarean section. Now if we start assigning people who can have a vacuum assisted delivery or forceps assisted delivery to cesarean sections, these rules may not apply. So what I'm saying is there's no significant difference in the intracranial injury rate for those three modes of delivery. And certainly doing a cesarean section during labor doesn't protect you from intracranial injury. If you then assign someone who could have a very easy forceps or vacuum, because we are reluctant to do it or unable to do it because of training, say someone has the lowest possible station, if you subject them to a cesarean section, I can infer from this data it's very likely that you are going to get a higher intracranial injury rate with a cesarean section. And what we are now starting to see is people who are involved in sort of defending clients in litigation and all that are seeing intracranial bleeds as a result of difficult deliveries and second stage sort of Caesars. So I think that is what will happen if we can't do the easiest of operative vaginal deliveries. There's a higher rate, of course, in sequential use of instruments, and so there should be caution about using the forceps after the vacuum has failed. So we must justify it on the basis that it's not that the vacuum has failed, but there has been a detachment just prior to, say, delivery. And what they concluded from this study is that abnormal labor is the risk factor for intracranial injury rather than the mode of delivery. So it's that prolonged labor as a result of non-progress, which is actually a risk factor. And the mode of delivery doesn't actually change that. So I want to conclude by saying that operative vaginal deliveries are certainly on the decline. And although there are medical legal concerns, we need to remember they're not supported by evidence. So we shouldn't just say, okay, I'm not going to do vacuum and forceps assisted deliveries because I'm worried about medical legal concerns. I think in the future people will be sued because they didn't do one, okay? And there's urgent action because we need to stop this sort of lack of training. And I would suggest that we need to go back to things like simulation, because now we can do simulation for obstetric emergencies, we can do that for operative vaginal deliveries as well. And we need to a certain extent to go back to the old way of apprenticeship where you attached yourself to a senior member of staff and they took you through these deliveries. And the appropriate choice of forceps, vacuum, or cesarean section will benefit women. So we still have to tell ourselves to go through that process. Say, can I do a forceps or vacuum delivery safely? We should always do it. And if we can't, by all means, we're not asking that we do the very difficult ones or the ones where the station is very high. And performing a cesarean section when a forceps or vacuum is the clear choice may indeed be harmful. Thank you very much.